Let's start. Our last speaker for the session is Marzyeh, who will talk about the pulse of ethical machine learning in multimodal health data. And my understanding is the title is empirically developed.
It is, in fact, empirically developed. I tested this title because, if you want to say, is it the pulse of something? Is it the beat of something? I had many different words. And I tested it with my students and then with my kids. And the kids are meaner than the students. And we settled on pulse. So it's a crowd pleaser. Everybody better be happy with it. So I'm going to talk to you today a little bit about how we use multimodal data in health and some of the work that I've done in creating actionable insights in human health. And in order to motivate you, I'm going to walk you through a real example of a real research study that we did, and it's how a lot of machine learning and health research gets started. Let's say that you're a PhD student at MIT, which, looking at the lack of wrinkles in the crowd, many of you probably are, and you get approached by a doctor and they say, we have patients, they come in to Mass General and they're having trouble breathing. But if it's a weekend night in the emergency room, then it's really busy and it's going to take a while for somebody to see this patient. What we'd like to do is take a chest x-ray, and then we'd like to have a system triage this patient. If they're healthy, we don't want them to wait around in the emergency room. It's a MRSA risk, it's a COVID risk, we'd like them to go home. But if they're actually sick, then we can have them wait around and a doctor will see them. All right, so the goal is, can we build a model to triage a patient like this, right? And if you have worked in machine learning in any capacity, you probably are aware of this pipeline, where you pick a problem, you collect some data, you define an outcome, you build a model, and then you consider deploying it. Right, we've all done this before, hopefully, if you're in the field. And we've already done this first part. We know what we need to do. We need to build this triage model for this emergency room setting, right? So let's do the rest of this. We can collect the 3 largest publicly available chest x-ray data sets available in the United States. That's over 700,000 images, so good sample size. It's from 3 different sites geographically, so good distribution. We can train a dense net, which is a kind of convolutional neural network, and it predicts a specific label, no finding. No finding means in the chest x-ray, we did not find a fracture or pneumonia or a pneumothorax or cardiomegaly. None of those labels are there. There's no finding. So the patient is healthy and they can go home. And then we're going to measure the performance. And if you're in the field, AUC is a usual metric that we all report our performance based on. If you're not in the field, higher means better, 0.5 is random, and 1 is perfect. If your model gets 0.1, you made an error, something's wrong. So this is our result. This is great. You can write up a great Nature Medicine paper about it. You can talk to your collaborators and say, we're ready to go, right? But it's not just us who have done something like this. This is a huge field. This paper is now a few years old, but demonstrates that even at this point in 2019, there were so many models that did at or above clinical level performance at predicting human diagnoses and prognoses and outcomes across the range of tasks in the human lifespan. And you can see here they do the same thing. They're choosing a task, they're collecting a sample size, they're reporting a performance with a specific model. But the question is, are all these models deployed? And if not, why not? Well, models right now are regulated advice givers in the United States. So the FDA actually clears algorithms. And this graph is old. It's over 600 models now that have been cleared by the FDA. And you can see there's many clinical subspecialties where people have developed a model and the FDA has cleared them. They said, you can go out and sell that. You can market it to hospitals. They can use that in practice. This is not the only way that AI makes it into a clinical setting, but it's one of the ways. And so let's go back to our demonstrative use case. We go back to the doctors and say, hey, you can now have this model and let's deploy it at Mass General. Okay? So the question is, you're all here. Let's say that I showed you that performance just now. It is a Friday night. You're at Mass General. They take your chest x-ray. You were having trouble breathing. You can wait for 2 hours at Mass General and see a doctor, or you can get triaged by the state-of-the-art AI model right now. How many people in this audience will get triaged by the state-of-the-art AI model right now? Okay, a third of the room? And would all the rest of you wait for 2 hours on a Friday night? Yes? Really? Okay, well, there are some skeptics in this room. So maybe you all are skeptical, and I'll ask, maybe during the panel we can discuss this later, why you're so skeptical. But maybe one of the reasons you're so skeptical is you saw one number reported there, right? This is state-of-the-art performance, but I've only given you one number across this really large data set. And so maybe you're wondering whether it works well for a patient like you. And so one way that we can try to establish this is by doing a subpopulation-based false positive rate for underdiagnosis. What that means is we're going to look at false positive rates, because if you falsely positively say somebody's healthy, they're actually sick, and your model has predicted they're healthy, and so you've sent them home when they actually should have stayed around to be treated. So we're going to look at this difference across different groups and call that a difference in underdiagnosis rates. When we run this audit, we find that there is the largest model underdiagnosis rate in female patients, young patients, Black patients, and patients on Medicaid insurance. And when you look at intersectional identities, so these would be Black or Hispanic female patients, they are underdiagnosed even more heavily than aggregated groups like white female patients. And so maybe you're concerned that this might be true because you belong to a specific intersectional group. And so this model doesn't perform as well for you as it does on aggregate. And there are other ways that AI makes it into these multimodal settings, right? Because health is inherently a very multimodal setting. There's clinical images, there's clinical tabular data, there's also clinical text. Right now, hospitals in the Boston area and beyond have a EHR software called Epic, okay? Epic has partnered with Microsoft to deploy GPT-4. GPT-4 is now writing doctors' notes for them and communicating with patients. So it's drafting the communication that doctors are sending to patients. Before this happened a while ago, we actually tested whether transformer models that have been specifically trained on scientific text tend to do patient note completion well. And so here we did an audit with Scientific BERT, or SciBERT, and we have a sentence that looks like this. It's from a real medical note from a Boston area hospital, and it goes, blank patient became belligerent and violent, sent to. And if we start this sentence with Caucasian or white patient became belligerent and violent, the model completes this note with they were sent to the hospital. But if we start this patient with African, African-American, or Black patient became belligerent and violent, the model completes this with they were sent to prison. And when I've spoken to hospitals around here about how they're evaluating this, they've said, well, this is kind of a version of GPT-4 that's been, probably checked on the other side because they're selling it to us. And when I was at NeurIPS and asked the OpenAI team about this, they said, surely the doctors are checking this. So nobody's checking. And I think that this is maybe an issue with the model development pipeline generally in health, in other areas like employment or finance, or even in education. We have federal laws that dictate that decision-making at a very high level has to be equitable, for example, with fair lending laws. And we don't have that in health. There is no large-scale federal law that says that all providers who are providing healthcare have to do so in an equitable manner that is being regularly audited by somebody. And so I'm going to walk you through some of the work that we've done. I'm only going to cover 3 topic areas because this is a short talk. And I'm going to walk you through data collection, outcome definition, and algorithm development, I think, unless I've swapped my slides. And we're going to talk about how ethical considerations impact multimodal data collection initially. The first thing you should know, if you don't know this already, FYI, is that your self-reported race is highly predictable from medical data, even when it's been redacted. What do I mean by that? I mean, if you give me a medical note that looks like the note on the left that has no mention of race because I've removed it, I can still predict self-reported race with extremely high performance in a corpus of millions of notes from New York and Boston. Okay, that's number 1. Number 2, if you give me your chest x-ray with no other demographic information, across many different sites, international sites and American sites, we can predict somebody's self-reported race with very high performance from your medical imaging data. Okay, so let those soak in. This is a fact. Now, one reviewer said, I went through a period where I only wrote papers to disprove reviewer 2. And so this is one of those papers that I'm about to present. One reviewer said, listen, you are showing that you can detect somebody's self-reported race from these medical images, medical text. This multimodal data has proxy information. Does that matter? Let's find out. So do demographic shortcuts matter in medical prediction? Well, we know that demographic shortcuts are encoded in medical data. So let's look across 3 different data sets. These are all medical data sets that have different kinds of data that is joined to them, right? So these are primarily imaging, and then they have tabular data associated with them as well. So we trained dense-net models again with empirical risk minimization. That means that we're optimizing for best overall performance, right? This is what you get when you optimize sort of a vanilla model objective. And we find that these models trained to predict disease encode demographic attributes, all right? That's nothing new. We're just revalidating in several different data sets that when you train a model to predict disease and chop off the prediction part and test whether the middle parts learned during training to also predict some demographic attributes, they do. We find that greater encoding of such demographic attributes is correlated with a larger disparity in prediction within those attributes. So the more you learned in the background that somebody is female, the worse you do at predicting these diseases in female patients. When you remove demographic encoding from model representations, you can encode or achieve these sort of locally fair models, right? So these are models that if you try to make sure that you have both a great overall AUC that's moving to the right, and you have a better fairness, which would be moving down, you see that using these techniques that try to remove information, they achieve these sort of optimal models that don't lose a lot of overall performance, but they're very fair. That's great. But what about in new settings? What if we take a bunch of data from Mass General and train these on these hospital data, and then we move it to a new setting? Well, we found that unfortunately, locally optimal model fairness doesn't transfer under distribution shifts. So if you are a great model at hospital A, you're probably not a great model for fairness, at least at hospital B. Models that have less demographic encoding actually achieve better out of distribution fairness than models that are explicitly optimized to be more fair in distribution. What this means is we have all of these fancy machine learning methods to force you to have a really fair model within the data that you're trained on. Those don't work as well as just removing all traces of the demographic data. And this is true both for optimization metrics you might use and for model strategies that are trying to do either of these. Okay, so how you encode data in these multimodal settings, maybe in a hidden way where humans can't tell whether you're black or white based on these chest x-rays, but models can, is very important in moving forward with ethical AI. The second thing you might not have thought about in these multimodal settings in health and other spaces is how we label our data. Okay, so second pop quiz of the day. My kids go to the local schools, and the schools have a meal policy, okay? And this meal policy prohibits high sugar. And so if they asked me to make a machine learning model where I take a photo on my phone and then I classify that, is it a meal that violates this policy or not, how would I do that? Well, I would take a bunch of photos like this, and I would ask a group of intelligent labelers like yourself, does this meal have high sugar content? By a show of hands, does this meal have high sugar content? This is Cocoa Puffs with whipped cream. So for those who are not raising your hands, diabetes might be in your future. Be very careful if you do not think this is high sugar content. It is. And so a majority of labelers, if they said yes, we would say, label this as a 1, this is a high sugar content meal. Okay? But I just tricked all of you. I asked you, does this meal have high sugar content? And you voted. I didn't ask you, does this meal violate a school meal policy that prohibits high sugar content? And you're saying, because you're smart people, it's an if-then. So if that's true, then that's true. But actually, 17 out of 20 labelers say this is high sugar, and 2 out of 20 say it violates a meal policy that prohibits high sugar. Okay? This is not just true. We thought it was a bug initially. This is not just true in this setting. This is true in 4 different settings where we routinely collect factual labels about the presence of something in an image. Is this high sugar? Is this dog large? Is this comment aggressive in a natural language setting? Is this clothing high skin exposure? So we collect labels about whether that factual feature exists, and we compare that to what happens, and we apply the rule, do a model prediction, train the models, which is what we normally do. We compare that to what would have happened if we would have told people we were training for a rule. And what we find is in all of these cases, machine learning models trained on these repurposed descriptive labels. Is there a large dog? Is this a high sugar meal? Is this comment toxic? They actually have a much lower performance because they have a much higher false positive rate. And importantly, this is always how we do machine learning. We always collect data as if just the feature presence is the real label. And then we don't ever just deploy a model to predict that dogs are large. We deploy models to make normative judgments in human evaluation systems. And so we're, by default, inducing this big gap. And this is particularly problematic in a healthcare setting. We find that the gap that you induce by doing it this way has a gap similar to if you had high rates of label noise, high rates of data subsampling, or just a much worse model. So here, making a better model, so the BERT model instead of the Albert model, that has a 1% impact, but using the right data, that would have given you a 6.5% impact. All right? What about when we develop algorithms? We're using this multimodal data. How do we actually use it well in a health setting? A very hot topic right now is whether we should use group attributes in clinical risk scores. I would encourage you not to debate this in any forum with any doctors because it is indeed a very hot topic and people have very strong beliefs about this on either side. Here's the argument in a nutshell. Using group attributes like sex or age or race can result in worse performance for a subgroup even though they improve the model's overall performance. Here's a real example. We trained a logistic regression model to predict sleep apnea. When you train it with sex and age, it's worse for younger male and older female patients, even though it's better overall. Okay, so this is a real example of this dynamic in practice. And so what do? There's so many clinical risk scores that use demographic data deployed right now, and nobody checked this. Well, our suggestion in this recent paper is you have to actually check this every time you make a risk score that impacts humans. And so there's two reasons that this sort of locally suboptimal model performance exists. It's when there's model misspecification, you can't capture necessary interaction effects between features and group attributes, or when during model selection, you do the thing we talked about before. You're tuning your hyperparameters to optimize for everyone, for example, in empirical risk minimization, and not trying to balance within different subgroups. And so what we propose is you just have to run an audit. And so in this case, if we were trying to figure out if you should include somebody's race in the prediction of acute kidney injury mortality, we would first run a model that's group blind, one model for everyone that does not have access to your race, okay? Then we would run a per group decoupled classifier. All right, so this means for every subgroup, train a new model on that subgroup. And if you have enough data, by definition, this will tend to do really well, right? Because if you have large data, then training some model that is hyper-specific to a subgroup should work well, all right? And then finally, compare this to what happens when you train one model that has access to race, but it's across all subgroups. And here we find that using race leads to worse performance across all metrics for Black men. But no one solution actually resolves all these fair use violations in the examples that we tested. You have to actually run this test and then determine what the right outcome should be as a result of this audit. It's something you have to think through. All right, I'm going to breeze through this last part because I think I'm running out of time. And so the last thing I want to talk about is how we deploy models. So let's say that I've convinced you, hopefully I have, that models will have biases and they'll probably be more biased against minority groups, okay? What happens when we deploy these models? Is there a way to deploy bad models such that they are safe? And so here what we did is we simulated a mental health crisis setting where somebody calls in to get support, and then you have to make a very simple triage decision. Should the caller get emergency medical help, or should we contact the police for emergency assistance? And we give people training, just like in that meal example. Contact the police if and only if there's a risk of violence. So those two labels are equivalent. If there's a risk of violence, you should call the police, okay? And then we test a bunch of doctors and non-doctors looking at this and see whether when we vary, whether we say somebody is African-American or Caucasian and Muslim or non-Muslim, whether they call the police more frequently on minority groups, okay? That's our control setting. You get no advice from an AI, we test you. Then we have the non-control setting. We have the treatment setting. Treatment number one that you're randomized to. You either get a racist GPT model that we train to be racist that always says that there's a risk of violence or you should call the police on minorities, so Black and Muslim people, or you get an unbiased GPT model. It's very easy to train a biased model, but obviously I don't recommend it. We passed our IRB review, I promise. Okay? so this is treatment number 1. Did you get the evil model or the good model? Okay, and this is something we think will really matter. Did you get the good or bad model? Second treatment, did you get the descriptive recommendation, the if condition, our AI system has flagged this call for risk of violence, or the then condition? The AI system thinks you should call the police. And again, these are equivalent because it's an if and only if. You call the police if there's a risk, and if there's a risk, you call the police. So this is the second thing that's randomized, whether you get the if or the then condition. And we're going to test whether getting the good or bad model or getting the if and then has different levels of effect on our participants. What we find is that at baseline, everybody breathe out, respondents, clinicians and non-clinicians, are not more likely to call the police on Black and Muslim subjects if they get no advice. That's great. Good baseline to have. When you give the biased prescriptive recommendations, when you use the evil GPT model and you tell them to call the police, both clinicians and non-clinicians are more likely to call the police on Black and Muslim people. However, when you use the same bad model and give the if condition, say there's a risk of violence, it's not true. The participants retain their original fair decision-making. This is a really important point because it's not how bad the model is that made the biggest impact in this specific study. It's how I gave the bad advice. And this is important because as we move forward with these systems that work really well in different settings, we need to know that people trust advice often when they're told what to do or it's explained to them that there's an action that they should take. Medicine has many black boxes, and so we need many systems that verify those black boxes so that we understand how they work. Because just explaining the model won't fix this for us. There's many ways that we can get to safe integration in health by mimicking some of the steps that fields like aviation have taken, focusing on regulation, cultures of safety and training. And obviously there's some things that will transfer well to some of these agencies, and there's other things that won't. And so this is something that we also need to recognize has some unique properties. In health, for example, in aviation, if you land a plane, everybody lands, right? It's one outcome for all people. But we know that in health, for example, gender concordance affects whether you have a good or bad outcome for heart attack survival. And this effect is driven by whether you have a male doctor and you are a female patient. But this is not true in aviation. I checked the statistics. Male pilots don't crash more when they're flying with female passengers, right? The other thing is if you have patient-physician race match, then it's actually great for a bunch of preventative care. But it is not true that Black passengers only get in-flight safety announcements from Black pilots. And finally, a majority of Muslim women experience poor quality care and maternity services. This hurts me personally because I went through this. But this is also true. Did you know that it is not random if you search me every time I go through the TSA? So aviation doesn't have it all figured out. Obviously, there are things that will map and that won't map. And we need to think really carefully about biases that might be encoded and how we work specifically within the healthcare setting. So this is going to be an ongoing process that requires diverse data and diverse teams. Thank you.